Then I'll ask one of the questions I wanted to bring up, and I'll address this to Jaime, is diabetes is a particularly complicated and frankly expensive disorder for a payer. Heart failure is a difficult and expensive disorder for a payer. Now you have this beautiful interchange between them, which has its own level of complexity. How does that change the burden to the patient and to society?
Yeah, thank you for that question. The reality is, and you can infer that from Dr. Desai's comments, is we're not dealing with separate entities. If you look at and there's a lot of pathophysiology we probably still need to find out. I actually work with the United Health Group, R&D group, and we are actually focusing on research trying to figure out what's the pathophysiology behind this, because is that intersection between the heart failure, the metabolic syndromes, the chronic kidney disease, what is common to them that we can address. So there is an effort, not just, we're not just a company that pays for medications. We're trying to figure out what's behind this.
Right.
How can we do, you mentioned at the beginning of the conference, the population health approach is how you translate those findings from the bench, not just to the clinical practice, but also to the population health side. So I think that global view of our patients is what we really need to take into account, and that's exactly how we're looking at it.
And how do you measure that or evaluate the changes? What do you look for to see how your programs are working?
Well, that's a great question. I'm going to tell you why it's a great question, because that's where we have a lot of opportunities in general, not just a single health plan, but in general as a society, is that we're so used to, number one, just pay for a visit. And that leads to, you've seen those articles in JAMA, for instance, about clinical inertia and some other journals. So the other part is that we used to, let's say we decided that, hey, let's work with metrics. And we said, check box if you have a patient on a statin, or check box if you have a patient on the right heart failure medication. To me, that's the job. I think the job is, how about if we contract with a healthcare system, with a provider or whoever is interested in it, said, how about if we check, what the box that we check is, how are the outcomes of 6 months or 12 months? Are you keeping people out of the hospital, preventing readmissions? Is the quality of life better? Because that's something that is also important to mention, is the patient-reported outcomes. We need to take into that account. Am I going to say that we're there? Not yet. Are we working toward that? You bet.
So I couldn't have asked for a better segue to our next question, because that tracks right into what I wanted to move into next. And I'll ask Nihar to weigh in on this. But, that gets at, what are the goals? Like, what are we trying to accomplish? And there are almost two sets of goals, if you will: the individual patient and sort of the population of heart failure and heart failure with diabetes patients. So, how do you look at those things?
Yeah, Neil, I think the best way to start, thinking about the answer to your question is to listen to the patients, and the patients that we see, whether they're in the hospital or in the office, they say they want to get back to life, and they want to feel better and be able to do the things that they have always done, and the things that they are aspirationally, kind of hoping to do. And I think that is the challenge that we face, is how do we get all of those patients back to have the lives that they want, and get back to the world that was their world before they got heart failure or a set of other clinical conditions. And I think there are a number of important things that we can do kind of along that front. I think, to Jaime's point, first and foremost, we've got to develop a systematic way to kind of capture symptoms and how people are feeling. And yes, that starts with a clinician during a visit, trying to engage with them around that. But I think for us to be able to kind of systematically incorporate and integrate, patient-reported outcome measure scales or other standardized assessments is going to be an important element as we think about kind of where we have to go. I think relatedly, of course, the clinician and the evidence-based, kind of practitioner in me, of course, is trying to say, well, of course, we want to prevent rehospitalizations, we want to prevent death, we want to prevent, ongoing kidney disease, we want to prevent other downstream utilization, if you will, in the system. And then at a population level, I think we want, to try and reduce the burden of disease, improve health, and then make sure that people are getting the best quality of care in a timely, efficient, and sort of manner. And so I think those are all the challenges, whether you're sort of going at the individual patient level, or then taking something back to at a health system level or a health plan level, or maybe even to a societal level, of how do we get people to sort of get to have the lives that they want, to contribute meaningfully to society, and for us to prevent unnecessary or excess utilization, if you will, which is a cost burden for payers or society that we can sort of ill afford.
You can sort of summarize this in a couple of ways, and this is actually interesting because it's the way the FDA tends to look at drugs for these kinds of conditions. I mean, one is feeling better, and we have therapies that make people feel better that probably don't make them live any longer. A diuretic, in heart failure, there's not really been any evidence that furosemide makes people live longer, but they feel better. You decongest them. And then you have the drugs that have now been studied that make people live longer. And I think probably the third arm of that you mentioned, Nihar, is keeping people out of the hospital. It is, I believe, correct that the number one cause for admission to the hospital in Medicare patients, people over the age of 65, is heart failure. Number one reason for admission. And for those of us that are old enough to have been in the hospital, it is not a pleasant experience. Nobody wants, being in a hospital and getting IVs and poked and prodded and all of that. So I think that, feel-good drugs are really important. Can you make people feel better? And then live longer therapies. And in some cases, we have pharmacotherapies that do both. And that's fantastic. But we can't expect every therapy will do both. But those that do become very valuable to patients. It's interesting because if you look at the labels for most of the drugs that we actually use, they're actually about living longer. That's really what people have tried to prove. Not as much actually feeling better. And I think that's a deficit historically in how we've approached drug approval, is to emphasize the live longer and stay out of the hospital, and not necessarily emphasize as much as we should the feeling better. And that's why some of these new metrics around feeling better that are now appearing in clinical trials are really important. I suspect we're going to talk about that later.